Hello, and thanks for taking part in this webinar series that is presented by the West Virginia University Injury Control Research Center. My name is Will Pigeon. I appreciate the opportunity to deliver this webinar today. I'm going to be talking about the relationship between sleep and suicide and opportunities for intervention that might present themselves with respect to sleep that may have an impact on suicide or suicide risk. I'm an associate professor at the University of Rochester Medical Center in the Department of Psychiatry and Department of Public Health Sciences, where I also direct a sleep research center. I'm also the director of the Center of Excellence for Suicide Prevention for the Department of Veterans Affairs in Canandaigua, New York. So, a number of disclosures. I'm not going to read through all of this. However, I am presenting this webinar series under my role as a faculty at the University of Rochester. I am nonetheless an employee of the Department of Veterans Affairs, so I need to let you know that the views or opinions that I express today are not those of the Department of Veterans Affairs, the National Institutes of Health, the United States government, or the University of Rochester. A couple financial disclosures and some significant support that I've received that has allowed some of the work that I'll be sharing with you today to be conducted. And I'd like to list my primary collaborators, and they are listed there at the bottom of this slide. The objectives for today, there are four. First, I'd like to review some impact of poor sleep on health. And at another time, I'll spell health correctly. I'd like to also provide some information so that we can begin to understand the risk relationship between sleep disturbance and suicidal thoughts and behaviors. I'll also be presenting some data with respect to behavioral sleep interventions and how they can address risk factors for suicide such as chronic pain, depression, and PTSD. And finally, I want to review some examples of sleep-related public health approaches that have been undertaken in the past, not with respect to suicide, but that might serve as a model, and that might be a jumping-off place for us to engage in some additional discussion. So, poor sleep, bad sleep, not good enough sleep, what's the big deal? Is it a big deal? Since I'm a sleep researcher, I tend to think that indeed it is quite a big deal. And I'd like to present to you some information that supports at least my belief that that's so. There have been a number of studies with respect to the relationship between sleep problems, and here insomnia specifically, and depression. We've known for decades that people with depression often have a sleep disturbance. Anywhere from 80 to 90% of those who have major depression have a sleep disturbance. Most of that sleep disturbance is insomnia. So insomnia is the inability to initiate sleep and or maintain sleep, and that continues for at least 1 month to 3 months and longer. There are also some daytime consequences associated with that, and that's insomnia. So in the current DSM-5 classification, those symptoms need to be present for 3 months or more, and that is called insomnia disorder. It has long been thought that when people who had depression had sleep problems, if we could only get the depression treated correctly, then the insomnia would dissipate or disappear, because insomnia was thought to be just a symptom of depression. Over the intervening decade or so, probably more at this point, the contention has shifted to, well, you know, insomnia actually is a disorder in its own right. And in addition, it is often the case that insomnia, in the absence of depression, if it continues on a chronic basis, can actually cause depression. And I purposefully use the word cause. There's enough information now to be able to say that insomnia has a causative role in the development of major depressive disorder. Of course, there are some people for whom insomnia doesn't pre-exist the first incidence of depression, but begins at the time of a depressive episode. That is true, but by and large, the data supports a causative role for insomnia and development of depression. So that's a pretty big deal. It's also true that other conditions, other sleep problems like sleep apnea can also contribute to depression. Other big deals with respect to sleep loss. The medical profession is one that tends to be engaged in shift work, and shift work can have some pretty dramatic effects on our ability to sleep or to obtain an adequate sleep to function properly. When that occurs, there are some fairly serious consequences of added sleep loss for days and weeks and months on end. It can lead to medical errors. So there have been some work showing that the incidence of medical errors can increase with the amount of 24-hour schedules, with hours of work that residents are engaged with in a week, and information that suggests that shifting work schedules for residents has decreased medical errors in some instances. Sleep loss has also been associated with a number of fairly dramatic events like motor vehicle accidents. It is thought that about a half of motor vehicle accidents fatalities are associated with drowsy driving, fatigued drivers, or drivers who have fallen asleep at the wheel. We can also have impaired performance when there is sleep loss in adolescence, and sleep loss in this case because often school start times are limited, and so for adolescents who are getting up at 6 o'clock to make it to their first class and not falling asleep until 1 o'clock at night, they may have only 5 or 6 hours of sleep opportunity to get the 8 or 9 hours that they need at the age of adolescence, and this might be what they look like in their 9 a.m. lab class. So sleep loss can impact performance in school, and for some people may also impact performance in cabinet meetings. Hopefully that's a chuckle and not a groan from the audience. So often my answer to is sleep a big deal, or is poor sleep a big deal, is to throw a couple quotes at people. And one of my favorites is, without enough sleep, we all become tall 2-year-olds. And that's from a great book of quotes called Dirt Farmer Wisdom. When we don't sleep well, not only do we not function well, but we sometimes don't act rationally. We tend to be more irritable. And in many ways, we might be throwing little 2-year-old tantrums that we might not otherwise be throwing if we were sleeping the amount of time that we need to sleep. So those were my more off-the-cuff examples of what happens when we don't have enough sleep. Here's one from work that we've done that I think is quite striking, and that is, I mentioned that insomnia can lead to depression. It's also the case that when insomnia is present, it can blunt the effectiveness of treatments for other conditions. So here again, the examples with depression. This was a study of 1,800 primary care patients who received a very good depression care management. Half were randomized to the care management that was experimental, and the other half to a control condition. And those in the depression care management group did far better than those in the control condition. This is a secondary analysis of that data, and first identifying at the beginning of the study, identifying those patients who had insomnia, and then following them through both arms of the trial to see what happened to them over time. And what happens to them over time is, if insomnia is present, there is a 2 to 3 times greater likelihood of not benefiting from the depression treatment compared to those who had no insomnia at baseline. So the tagline here, insomnia can blunt the effect of depression treatment. Some epidemiologic data also supports my claim, and the claim of many others really, that sleep loss can negatively impact health and functioning. Here the data is from the National Comorbidity Replication Study, thousands of individuals, and what we're looking at is a table that is adapted from the paper from which this is reported, and these are adjusted odds ratios. So these are odds ratios for having either ideation, which I will be circling, suicide attempts, or suicide. And they're broken out by different kinds of sleep problems. So early morning, waking up too early in the morning, difficulty initiating sleep, difficulty maintaining sleep, and any sleep problem at all. And each of those is associated with an increased risk for having ideation, planning, or attempting suicide. We've also published a meta-analysis, so a study of studies, looking at all studies that we could identify that assess this relationship between sleep disturbance and suicidal thoughts and behaviors. And what we found in this meta-analysis, it was 37 or so studies overall, we found that, again, sleep disturbance, any kind of sleep disturbance, increases the risk of having suicidal thoughts or ideation, having a suicide attempt, or a death related to suicide. And that the range of the additional risk is nearly 80 to 100% greater in those that have a sleep disturbance compared to those who don't. And if we look at just one condition, here insomnia, so we were talking about having any kind of sleep problem, and next if we just look at insomnia, what are the risks of having insomnia? What are the risks related to having insomnia with respect to suicidal thoughts and behaviors, and really in the same ballpark. Some newer work that we've completed, and I wanted to present this today in this webinar because there's so very little work when we're talking about sleep disturbance and suicidal thoughts and behaviors that is focused on individual conditions, individual sleep disorders. There's a good deal of work with insomnia specifically, which is why I showed you that. Only 2 studies that we're aware of, and this is one of them, that assess the relationship between suicide and sleep apnea. So insomnia is the most common of the sleep problems, the most common of all sleep disorders, and sleep apnea is the second most common. And sleep apnea, of course, is cessation of breathing while asleep. Occurs in somewhere between 4 to 8% of the population, of the adult population. So here the data is from another large cohort study, and this is 2014, the National Survey on Drug Abuse and Health, 40,000 individuals. And here we were able to identify those with and without sleep apnea, and in a similar fashion, attempting to see if the presence of sleep apnea is associated with increased odds of having a suicidal thought, having plans for suicide, and having a suicide attempt, a non-fatal suicide attempt. Here, unlike in the other studies, the relationship was similar for ideation and planning. So apnea is related to ideation, and presence of apnea is also related to planning about suicide, which is a more severe form of suicidal ideation. But the relationship didn't hold in this study for sleep apnea and suicide attempts. We're not sure what that means, the fact that it was true for ideation and planning and not attempts, but nonetheless, some evidence that not only is a sleep disturbance overall a risk, contribute to risk for suicidal thoughts and behaviors, and that insomnia is one of those conditions that is specifically associated, and now potentially a fairly strong signal that that's true for sleep apnea as well. We've also, and this study is under review, so I can't give you a citation. At the bottom, it's simply the names of the authors on the study that's under review. Here, we assessed medical record data and pharmacy benefits data from the Department of Veterans Affairs. And we were assessing in 70 or more thousand individuals the risk associated with medications that we use for sleep. So these are sometimes called sedative hypnotics, and some of you know this, but I'm speaking more broadly for the broader audience. There are medications for sleep that are FDA approved with an indication for insomnia. Those are things like some of the benzodiazepines that we've had for decades, but also not that new anymore, the zolpidem and zaloplan, esopiclone, the non-benzodiazepine benzodiazepine receptor antagonists. So Ambien, Lunesta, and so forth. And in addition to those medications, there's a fairly large off-label use of medications for their sedating side effects or their sedating profiles that are used for insomnia. If you're a prescriber, I'd like you to guess right now what the most commonly used medication that does not have an FDA indication for sleep is. And if you guessed trazodone, you're correct. And now let me ask you, what is the most commonly prescribed medication in the United States for insomnia? And the answer is, again, trazodone. Trazodone is more commonly prescribed for insomnia than any of the medications that have an indication for insomnia. So in the Department of Veterans Affairs, in the years that we looked, zolpidem actually was the most common medication prescribed, and trazodone was second. So what we wanted to do here is, in the VA, zolpidem is at the top of the formulary, and clinical guidelines support the use of zolpidem if you're going to use a pharmacologic agent for insomnia. We wanted to compare suicide attempts in individuals who had first use, so first use of a sleep medication in a 12-month period. And we looked at the medication that they used. They couldn't have any other sleep medication on board at the time, so they have a single sleep medication. And then we looked at the next 12 months to see if there was a suicide attempt. And the overall number of suicide attempts were low, but nonetheless, they varied across medications used. And we wanted to compare zolpidem to each of the other medications. So what is the most commonly prescribed medication in the VA during this time frame? And it was zolpidem. Compare the other medications in terms of suicide attempts. So I'll direct your attention to the middle column first here. And we have suicide attempts. And first we have the raw number, and then in parentheses we have what that number represents in terms of attempts per 100,000. So what we see, and we'll be looking here at the number in the parentheses. So trazodone, 84 per 100,000, zolpidem, 51 per 100,000. What is the risk of a suicide attempt using Cox proportional hazard ratios? What is the risk of having a suicide attempt if you're on trazodone compared to being on zolpidem? And the risk, if we look in this column, is about 65% higher. So hazard ratio of 1.65. Here's the confidence interval for trazodone compared to zolpidem. And a similar model comparing all benzodiazepines, because each of the individual medications, there weren't enough to do them individually, so we combined them into one class. So benzodiazepines, here, there is a difference visually or descriptively. So the rate is 65 versus 48. Why is it not 48? Why are 51 and 48 different numbers? If we're looking at zolpidem, we have a slightly different cohort because we're matching on all control variables that we can. So 65 to 48, higher descriptively with benzodiazepines, but in our models, not significant. So it looks like a 36% increase. However, the confidence interval is too wide, so that's not a significant finding. And looking next at antihistamines. So antihistamines you can get over the counter, but they're also prescribed. Here, antihistamines also appear to represent an additional risk for suicide attempt above and beyond the risk that zolpidem provides. So it's not that prescribing zolpidem is without risk at all. So the rate of attempt in those prescribed zolpidem was in around 50 per 100,000. And as a comparison, the rates in the adult population, in the adult general population, are far lower than this amount. But this isn't the general population. So long-winded way to say sleep medications might be a suicide risk. Question, what's riskier, not treating insomnia or treating it with a sleep medication that's associated with its own risk for suicide? Is it possible that improving sleep can be considered suicide prevention? We've argued that, and others have done so as well. This is just a slide so that you can look these up if at all interested. These are both commentaries, so not data, but commentaries with some nice review. So why even consider treating insomnia as a suicide prevention strategy? Well, I've already told you that insomnia is associated with suicidal thoughts, suicide attempts, and suicide. And I've also told you that insomnia is strongly associated with a number of psychiatric conditions. I've talked mainly about depression, but it's true that insomnia is strongly associated with PTSD. Both depression and PTSD are themselves risk factors for eventual suicide. And on the non-mental health condition, small list that we have here, chronic pain, which is itself a risk factor for eventual suicide is also highly likely to be associated with insomnia. So insomnia in chronic pain, 70 to 90% of the population with chronic pain also has an insomnia problem. It's also true that insomnia is highly prevalent among many patients, but among primary care patients, and that primary care patients go to primary care to get a lot of their care, including their mental health care, including their care for sleep. It's also true that primary care is one of the last places, and for a majority of patients who are suicide decedents, it's the last place in the medical system that they were seen. So if we're thinking about the connection between sleep and suicide, and here we ask, well, where are the patients that may have sleep problems or may be a risk for suicide? Well, like many things, they may be in primary care. And primary care is a place where we can do interventions. And finally, with respect to why consider insomnia as a suicide prevention strategy, it's treatable. We can treat it. So I showed you data on insomnia medications. We have insomnia medications because they tend to work at least well enough to get an indication from the FDA. And I told you we have lots of medications that have no FDA indications that are used off-label. I'm not recommending off-label use, just noting that it occurs. And presumably it occurs because the prescriber believes it works or the patients believe it works. There are some clinical practice guidelines with respect to treating insomnia. And for a couple of decades, the guidelines said both pharmacotherapy and non-pharmacotherapy could be considered first-line treatments for insomnia, that the evidence was strong enough that that was the case. More recently, the evidence, the latest clinical practice guidelines recommend and pretty boldly recommend that behavioral therapies be the first-line treatment for insomnia. And typically that's cognitive behavioral therapy for insomnia, which I'll be calling CBT for insomnia, be the first-line treatment for insomnia. And that pharmacotherapy be considered when CBT is not available or the patient fails CBT. So the pharmacotherapy should be a second-line treatment. Nonetheless, we have treatments that work for insomnia. So potentially, insomnia is a modifiable risk factor for suicide. So let's see how we can address that in patients who have comorbidity. So I wanted to present some data that comes from some of our studies. The first study is in a chronic pain population, and here the effort was to treat patients who have chronic pain and insomnia, and to treat them with either a behavioral strategy for pain, a behavioral strategy for insomnia, or a combined insomnia and pain strategy, and compare that to a control condition. And I'm going to just show you data that is on the impact of those interventions on insomnia only. So if we treat the pain, not surprisingly, this bar is the pain group, the group that got just the pain treatment. The light blue is pre-treatment. The dark bar is post-treatment. And then we see a fairly small drop, and it's not a significant drop, in insomnia severity in the group that got a pain treatment. Not surprising. And in fact, it was no different than a control group that got no treatment at all. It's not surprising, but again, some people think, well, if you treat the pain, won't the insomnia problem go away? Well, that's not the case. If you treat the pain, you may improve pain. What if you treat insomnia? Well, if you treat insomnia with just an insomnia treatment, you get a very large and very significant drop in insomnia severity. What if you treat both pain and insomnia? Again, a very large drop, and a slightly larger drop when you have a combined insomnia and pain intervention. So this is one of the first studies that we did to show that you could treat a person who had insomnia in the context of another condition or had a comorbid condition, here chronic pain. We next approached a very small study to just demonstrate that we could also do this with combat veterans. So veterans who had PTSD and were combat veterans. And here we have three different outcomes. Insomnia severity. Again, we have pre and post measures. Here the yellow bar is pre-treatment and the blue bar is post-treatment. Insomnia severity, again, a very large drop in insomnia severity. And I'm going to suggest that you should expect that to be the case. When we deliver CBT for insomnia to someone who has insomnia, we should expect it to work, because it does, and it works fairly well. And what the field has shown over the last decade and a half is that it even works when there are other conditions, when there are comorbid conditions. Here, PTSD. So a very large decrease in insomnia severity, but also a large decrease in depression severity, as well as in PTSD severity. So here's an important point. We didn't treat depression, we didn't treat PTSD, we only treated insomnia. And we got significant decreases in all symptom severity levels. Small study, 15 veterans, single-arm study, no controls. So just a signal that that can be done. Larger study, just completed. So this is not published data. It's under review data. This was an NIH-funded from a study in R1 delivering CBT for insomnia. Again, here the patient population, the research participants are women who have been exposed to interpersonal violence in the past year. And they also met criteria for major depressive disorder and PTSD, as well as having insomnia. There are two parts to this study. If you look at the diagram, the graphic, the individuals were randomized first to receive either CBT for insomnia or the control condition. And then they were measured on a number of outcomes. And then both groups, everybody gets cognitive processing therapy, which is an evidence-based treatment for PTSD that's been shown to improve PTSD. So half the group gets their insomnia treated and then their PTSD treated. The other half gets no insomnia treatment, but still gets their PTSD treatment. So I want to show you the results of that study. About 110 participants were randomized. Here we have, in line graph instead of bar graph, we have the blue line represents those folks who did not get the insomnia intervention. And the red line depicts the mean values of those who got the insomnia intervention first, and this is what they looked like in the middle after the insomnia intervention versus no insomnia intervention. And then everybody gets the trauma treatment, and this is where they end up. So the outcome here is PTSD severity is measured by the gold standard measure for PTSD, the clinician administered PTSD scale. You see the p-value here. And the effect size, ES is effect size 0.53. That's a moderate effect size. It's similar to what some PTSD treatments provide in terms of impact or effect. So here again, we at this time point, we haven't treated anything other than insomnia, and we begin to have a difference. And then at this time point, patients continue to do better, but they do much better if they've also received the insomnia treatment first. Same graphic, except we're now talking about depression severity. Slightly larger effect on depression severity of 0.8 is considered a large effect, but the graph looks the same, doesn't it? So this indicates to us that treating insomnia in those with PTSD and fairly severe PTSD in a fairly unique population that's underserved generally has an impact. I didn't show you the insomnia results because they're good. Has an impact on depression and PTSD. So again, treat the insomnia, you get a nice impact on sleep, depression, PTSD. And then what this study then provides is, well, and if you provide insomnia treatment prior to a PTSD treatment, you get a bigger improvement overall. So this talk is supposed to be about sleep and suicide. So how about some studies related to sleep and suicide? The information, the data that I was presenting to you is quite a few years worth of study that gets us to the following point. And that point is treating insomnia in patients who are endorsing suicidal ideation. So they're thinking about suicide and they have insomnia. They also have depression and some PTSD symptoms. So here I'm going to be presenting data on a small randomized trial. There are 50 participants, and they were, in this case, randomized to something akin to cognitive behavioral therapy for insomnia. We actually called it brief CBT for insomnia, pardon me. Brief because 2 sessions. Standard CBT is anywhere from 4 to 8 sessions, typically 50 to 60 minutes. Here, I mentioned earlier on that we can find a lot of patients in primary care for many things, and patients in primary care who meet these criteria that this study was interested in. So if you're going to treat patients in primary care, you need to treat them in a primary care manner or function in a manner that makes sense or is consistent with that milieu. And what is consistent is smaller number of sessions, so briefer in frequency and briefer in duration. So here we delivered 2 30-minute face-to-face interventions and 2 20-minute phone interventions. So 4 sessions total, but 2 of them are face-to-face, 2 of them are on the phone. On average, across the 4 sessions, slightly under 30 minutes on average. So in sum, 2 hours of total treatment time. So patients were either randomized to that condition or to receive a control condition, which was simply, hey, if you're getting treated for depression or PTSD or suicidal ideation, continue to do that. Go ahead, don't change that. If you're going to get treated for insomnia, could you wait? Could you either disenroll from the study and go do that, or wait a bit? And the other folks were also encouraged to get treatment as usual if they were getting any, in addition to their brief CBT for insomnia treatment. So here are the results. Here, what I'm showing you is % reduction in the severity of symptoms. So they're somewhere between 50 and 60% reduction in the severity of symptoms pre to post treatment for insomnia, again to be expected, for depression, and for PTSD. I'm sorry, let's do that again. Insomnia, depression, suicidal ideation. So here's suicidal thoughts measured by the Columbia scale. There's a Columbia scale for suicidal ideation. There really is a Columbia scale. The acronym is CSSRS, and I can't for the life of me think what it stands for. So the CSSRS has a subscale called the Suicide Severity Intensity Subscale, and that's what we're measuring here with suicidal thoughts. So a decrease here, not as big a decrease as we see with depression compared to the control condition. So it's in the same range. It's a 60% or so decrease, but compared to the red bar, that's the control condition. And the control condition has somewhere between no improvement in insomnia to about a 25% improvement in suicidal ideation intensity in the control condition. So pilot study, N of 50 people, but one of the few indications that addressing sleep can impact suicidal ideation. So this is not suicide attempt, this is not long-term outcomes related to suicide, but thoughts of suicide. So I want to end just with a couple thoughts and a couple pieces of data that's not ours, but comes from elsewhere in the sleep world, in the public health world. So these are small studies. Can we address sleep and sleep problems on a global scale, on a large scale? 3 examples where that has been done. So for those of you who are public health oriented, if you may know about this work, and if not, know about this work. And I want us to be able to potentially discuss how this prior work can lead us, hopefully, to addressing sleep problems at a public health level that may impact suicide rates, suicidal thoughts, and behaviors. So the first study, the Minneapolis School District study, back in 1997, in that school year, the school district decided to delay school start times in their high schools. So there were 7 central high schools. They delayed school start time by almost an hour and a half, from 7:15 to 8:40 a.m. start time. And the reason is, if we have a later start time, presumably, hopefully, kids can sleep later and get close to adequate sleep during the week. And the outcomes 4 years later compared to high schools in another but nearby school district that were used as a control condition. Here are the effects. So hours of sleep first. So on a weekday, what's the average number of hours per sleep in the delayed start time high schools? 7 3/4 hours, close to 8 hours of sleep compared to 6 3/4. So about an hour difference. What about weekend sleep? Well, even with this much sleep, adolescents are still sleep deprived and they are still going to catch up on weekends. So there was no change, no difference between the high school groups in weekend sleep times. But look at this last bar graph. So yeah, so they're going to sleep more. So what are they going to do? Hours spent on homework per week. Huge difference. So that's interesting. And then so this graphic on the right, what are the differences between the Minneapolis high schools and the blue, the control districts. This is number of days in the last 2 weeks. Did you oversleep or were you tardy? So this was actually a significant difference. All of these were actually, but visually you can see less tardiness, less oversleeping, less falling asleep in class, and fewer days homesick. So I would consider that a public health related approach to sleep loss in adolescents, and that the intervention, delaying school start times, had in Minneapolis a pretty good effect. So Minneapolis has continued to do this and collect data. And by the way, if it's probably the case that some of you are in school districts that have or are considering a delay in school start times. It's estimated that somewhere between 10 and 15% of the country now has gone to a delayed school start time. It's a big fight at the individual school board level, but it makes a good deal of sense for the health and welfare of adolescents. So another example, drowsy driving. So I mentioned it's thought that at some point half of fatalities related to falling asleep or being drowsy or being fatigued. So, so what these pictures show are rumble strips, familiar to everyone now, but not familiar to everyone 25 years ago. What was the impact of rumble strips? Well, number of studies now, and who knows if it's just the rumble strips, of course, but in a number of studies, anywhere from a 15 to 80% decrease in the kinds of accidents that are those associated with fatigue or sleepiness, where there are few brake marks or last minute brake marks. So people are just driving off the road. So the amount of those kinds of accidents decreased pretty significantly, with most states reporting 30 to 40% reduction. In New York State, some of the largest reductions observed, and here you can see what this percentage comes from. So the number of crashes in the time period from the early 90s to the mid to late 90s. Final example I'd like to give you, and I think this is the most striking, maybe because the colors are a little striking. So a lot of data that we're looking at here. In the 90s, there you might recall a campaign, or not, but it was called Back to Sleep. And the idea here was that a lot of sudden infant death syndrome was related to children sleeping on their stomachs and suffocating. So there was a public health initiative to train parents, to train the populace, to train us to put our kids on their backs. So the Back to Sleep initiative. So what we're looking at is the rate of SIDS starting in the late 80s, and this is per 1,000 live births. So that's what the bar graphs represent, and you'll see they're going down. And the green line is percentage of parents, infants, homes using Back to Sleep. And we go from 13% to 75% as the SIDS rate decreases from 1.3 to 1.4 to in the 0.5 range. So tremendously impactful sleep-related public health campaign. And I give those examples partly because of the audience and partly because I want to ask this question. Can we develop public health approaches to improving sleep that reduce suicide? So I mentioned that we have interventions that work, but those interventions that have to be delivered by people or prescribed by people, potentially delivered over the internet. But are there ways to reach the greater public, the general public, in a way that can begin to reduce suicide? Not a question I'm going to answer today. I want to put that question out there. So thank you for your time, and I do hope we engage in some discussion around some of these issues.